Week 6, Chapter 18, Healthcare Economics. The learning objective for this PowerPoint specifically is identify selected issues related to nursing and healthcare economics. There's many challenges and opportunities. The challenges include the economic changes, which made it necessary to find new ways of delivering needed services within the new structures of payment. Also, rising costs meant a reduction in staff, and there was also a shift from quality care to cost effectiveness and profits. Some opportunities, because of the lowering costs, creates opportunities for nursing to expand practice and create new nursing roles. Advanced practice roles have increased in outpatient and community settings. We can also influence new directions for policy and delivery of care. Some issues are demand versus supply of healthcare. In the 1980s, the cost of medical care increased faster than the gross national product. The demand for expensive care outstripped the ability of payers to pay and spiraled out of control. In the United States, we were the only industrialized nation without a national health policy. But in 1965, Medicare and Medicaid were developed. Another issue is that bills for nursing services are bundled with flat daily charges. We're actually billed under the room rate for acute care. It hinders the nurse's ability to receive payment from third-party payers. However, there are some nursing organizations, such as NANDA, that have initiatives to help quantify nursing care. Cost containment strategies. First, competition was one. In the 1970s, regulations changed to permit competition among healthcare providers and insurance agencies. Competition actually had little effect on reduction in cost. There was also price controls. There was freezes put on physician fees. There was limits to reimbursement to physicians and hospitals for services provided to Medicaid clients, and also there was price controls put on group self-insurance plans. In 1982, the Tax Equity and Fiscal Responsibility Act led to restructuring of healthcare delivery. It changed payment for Medicare from retrospective to prospective payment system, which is a PPS system. Reimbursement was also made to a system now called Diagnosis-Related Groups, or DRGs. And what that meant, there was a pre-treatment diagnosis billing, and the hospital could lose money if costs exceeded the fixed amount. Effects with the new payment system included earlier discharge, decline in inpatient admissions, rise in outpatient services, and increased focus on cost of care. More cost containment strategies included the creation of alternative delivery systems, which included HMOs, PPOs, PHOs, and managed care. HMOs are health maintenance organizations, which are basic and supplemental health maintenance and treatment services. The HMO prepays a fixed periodic fee set without regard to the amount of services actually provided. The preferred provider organizations is a group of physicians or hospitals that provide services at a discounted rate, which is usually negotiated by the insurance company. And also physician hospital organizations, which is a joint venture between physicians and hospitals. They combine resources to provide managed care alternatives and medical services, and they work with a variety of insurances. We also have managed care, which is a healthcare system whose goal are to provide cost-effective quality care that focuses on improved outcome. Their emphasis is on cost controls, customer satisfaction, health promotion, and preventative services. Hospitals also develop strategies to reduce costs and ensure quality. And what they came up with, case management, and case management avoids duplication of services, prevents delays in services, and facilitates movement through the healthcare system. Another cost containment strategy is vertically integrated health services organizations. Prior to the 1970s, delivery for care was a single not-for-profit hospital. Now the present scope has been expanded to include wellness centers, ambulatory care centers, outpatient surgery centers, and home health services. So payment sources in the United States, like I said, in 1965, Medicare and Medicaid came about. Medicare was intended to provide care to the elderly, disabled, and individuals with renal disease. It consists of hospital insurance and supplemental medical insurance. 95% of the elderly are covered in the United States. And Medicaid is medical assistance for individuals and families with low incomes and fewer resources. Medicaid is jointly funded by federal and state governments. It's the largest funding for poorest people. States actually have discretion in determining eligibility, and states pay providers directly on a fee-for-service or through prepaid arrangements. And also Medicaid may pay for long-term care. It also provides state children's health insurance programs, which is known as SCHIP, the SHIP programs. However, that has changed. Internationally, different countries may have socialized medicine or mandatory medicine, and Sweden, for example, Sweden and Great Britain they have socialized medicine, and so does Canada. Usually it's publicly funded. They may levy taxes to finance them, but usually the government is the one that is maintaining the insurance. So it's usually funded by the taxpayer and possibly the employer, but it's administered by the Department of Health. Okay. And usually the goal is to provide reasonable access to medically necessary insured services on a prepaid basis. Germany, on the other hand, has mandatory insurance healthcare, and that's the first country to institute national insurance-based social health program. It's based on private practice physicians and community, church, and municipality affiliated hospitals. It's funded by income-adjusted fee paid by both the worker and employer. It's a private system that uses universal coverage. In the United States, as you are well aware, we have the Affordable Care Act, or the Obama, or some people refer to it as Obamacare, which provides Americans with better health security by putting in place comprehensive health insurance reforms that will expand coverage, hold insurance companies accountable, lower health care costs, guarantee more choice, and enhance the quality of care for all Americans. The Affordable Care Act actually refers to two separate pieces of legislation. They are the Patient Protection and Affordable Care Act, and also the Health Care and Education Reconciliation Act of 2010. That together will expand Medicaid coverage to millions of low-income Americans. On the PowerPoint text for this PowerPoint, I provided the link to hhs.gov, which would give you further explanation about the Affordable Care Act if you would like to go on and find out more about that. As far as financial management, hospitals can be either profit or nonprofit organizations. Public organizations, hospital ownership, public or private for-profit. So public are usually federal, state, and local government agencies, while private for-profit are privately owned, serving paying clients. It's owned by a voluntary board of trustees, provide care to paying clients, and they are required to provide charitable care. In the United States, healthcare is mostly provided by nonprofit enterprises. 15% are for-profit, and in the 1980s, the shift of hospitals and physician groups to private sector, referred to as the corporatization of healthcare. But most of our hospitals are not for profit. And lastly, financial management. It's also, as far as cost and budgeting, nurses need to understand the business of healthcare that are used by, and there's something called cost accounting that is used by hospitals and other organizations. It's methods of accounting total cost of the business and tracking and allocating those costs to specific services. And that's it.